Let's have Janet and then Mike Rosenblatt. All right. Well, I agree that we need a business case and we need actionable items that we can do, and we need a sort of hair on fire. What can we really do now that there's an urgent need to do? And beyond that, Marty, I don't agree with you. So what could we do now, and what are the compelling reasons to do that, and what parties could participate? All right. Number one, to use this social media and the power of the internet. We have thousands of diseases where we don't know the natural history of that disease because they're rare and nobody's followed it. And that is the most important thing in contemplating any kind of medical intervention, is what happens to people over time and what is the burden of disease. And we can collect that information. I mean, it is a tragedy that most people's course of their illness is not used to further treatment of that illness. That's terrible. And in cancer, that is terrible. In cancer, I agree that we need to match up the targeted therapies with the genotypes, but I think we ought to do that in an orderly and systematic manner. I think the I-SPY trial that we are running is an example of that, but we need to move that out into the community and invite people who have cancer to get their tumors, get the genotypes or other types of measurements on their tumors, and then invite them, have a large-scale trial, which is a kind of data sharing across companies, across investigators, so that we can match people to the appropriate investigational and existing drugs that are most likely, to have effects on that tumor, and then adapt that trial over time, which is what we're doing in the I-SPY trial, to begin to select out those marker intervention pairs that are successful. Now, in clinical trials, what is the reason to share data? The reason to share data is that is several-fold. Number one, if you can share a clinical trial, you can share the placebo group, and you decrease your numbers of people you have to enroll. Number two, most clinical trials are not designed to answer all the questions you want to answer about anything. They can only answer a few little questions, and so we end up, everybody complains about incomplete data. We have in the past combined clinical trials to get data about, for example, the safety of antidepressants, et cetera, et cetera. These combined analyses, but much better would be actually to conduct the trials combined or of similar design, or at least combine them afterward. Registries and other types of combined data would be very important, and I think we could use the power of the internet to attract people. All these things are doable now and would not require tremendous effort, I think, on anyone's part. The data standards are very important. I heard that some people during the course of this discussion have downgraded that, but it gets to the quality and the utility of the data. If you call something different, and everyone calls it something different, you can construct an algorithm to lump all that together, but it takes a lot of work, and it'll be slightly wrong, because the Venn diagrams are overlapping. So much better is develop consensus standards of what we call things, and for clinical trials, that's what we're doing with CFAST and CDISC and CPATH, and I think that we really need to push ahead on that. You don't have to standardize every data point, but certain things, for us it's terrible. We have gender, it can be female, it can be yes, it can be one, but somebody else would decide female is 2, So is it 1 or is it 2? And that's in the same company in different trials. So and you could get a machine that was smart enough to figure this out, maybe, but that would be extra work that you have to do. So I think underlying all this would be standardization, but I think there are compelling cases all through, the types of trials, from everything from, and then to Sentinel, which I mentioned earlier, we have a common data model, we have all those lives. Why not try to expand that as a national resource so that people who wish to do research on health data, everybody could use the same resource. And what we would be doing is using different coordinating centers to access those data, which would have to use different governance rules, depending on whether it was research, public health surveillance, whatever quality evaluation or so on. So I'll stop there, but that is my theory, is that I totally agree with you. We ought to think of actionable items. Everyone agrees that sharing clinical data is a public good, that the data are basically owned by the citizenry, and that we really need to figure out how to leverage these data as much as possible because it's so precious.